Hi, good morning, everybody. Thank you for coming both in person and online to Dr. Russell's lecture. My name is Aiden. Dr. Leonard is not able to be here today to do the welcome remarks, so that'll be me. Just a few housekeeping items on the lower left-hand side of your screen is the QR code for CME credit. If you go ahead and scan that before we get started. Next slide. We wanted to start with our Stanford University land acknowledgement, where we acknowledge that we sit on the Muwekma Ohlone tribe's land, and consistent with our values of community inclusion, we would like to acknowledge the importance of this land to its peoples and Stanford's relationship to Native people. A quick plug for personally one of my favorite events of the year is the 15th annual Pediatrics Research Retreat later this month. Please come for the day to see what various members of our department are doing, including shameless plug, many of our residents as well. The registration link is over here, and it's also in your emails as well. Awesome. And then Dr. Kim will be doing the intro for Dr. Russell. Awesome. Thanks for coming.
Thank you very much. It is my pleasure to introduce today's Grand Round speaker, Dr. Christopher Russell. Dr. Russell is an associate professor in the Division of Pediatric Hospital Medicine. He recently joined our division in August of 2023. I will say the transition has been seamless. And this is a good thing when I say this, that it feels like he's been here a lot longer than just the past, let's say, 9 months. So he's just really just encapsulated what our division stands for. He participates and shares his wonderful knowledge and wisdom to our younger and junior faculty. So thank you so much, Chris. Now, focusing on his research, he focuses on developing evidence-based care for hospitalized children with medical complexity, including acute respiratory infections. His research efforts have been recognized through receipt of the University of Southern California's Clinical and Translational Science Institute's KL2 Mentored Research Career Development Award, the APA's Young Investigator Award, the NIH Loan Repayment Program, and a large grant from the Gerber Foundation. In August 2021, he received a 5-year R01 award from the Agency for Healthcare Research and Quality to study bacterial respiratory infections in child with tracheostomy. Outside of his clinical research responsibilities, Dr. Russell focuses on research mentorship of medical students, pediatric residents, and PHM fellows, as well as improving representation of underrepresented minorities in medicine throughout the continuum of physician training. At a national level, Dr. Russell is the chair of APA's Membership Diversity and Inclusion Committee and is on the executive committee for the Pediatric Research in Inpatient Settings Research Network. He's also active in the AAP and currently serves as the associate editor for the journal Hospital Pediatrics. So it's my great pleasure to introduce today's speaker again and invite him to the podium. Dr. Christopher Russell.
Thank you, Daryl. Good morning, everyone. I'm so excited to be here to be able to sort of introduce my work to the larger Stanford community today. I'm going to be speaking about respiratory infections in children with medical complexity. I have no conflicts of interest. I'm funded by the Gerber Foundation, HRQ, and the NIH for work that's going to be presented today. I do receive honorariums for some of the work that I do as an associate editor for Hospital Pediatrics, as well as being on a standing study section for AHRQ. And I'm not going to intentionally talk about any off-label products today. Really, the objectives of the talk today are threefold. One, to describe the epidemiology of acute respiratory infections in children with tracheostomy. I want to appreciate the challenges associated with diagnosing and managing acute respiratory infections in this population. And then we're going to talk a little bit about identifying racial, ethnic, and socioeconomic health disparities experienced by children with medical complexity. And the fourth objective that's not listed on here is I really also want to highlight amazing work that's being done by pediatric hospitalists as well as pediatric generalists across the country. So children with medical complexity, I think it's a sort of like one of those, you know it when you see it, but it's a child who has substantial healthcare needs, repeated hospitalizations, and high use of health resources. So while they account for about 10% of hospitalizations, they account for about half of hospital charges and 70 to 90% of technology use. And as you can suspect by the name of my talk, acute respiratory infections in children with medical complexity is one of the most common reasons for hospitalization in this population, and accounts for billions of dollars in annual healthcare costs in the United States. So children with medical complexity are getting admitted often. In fact, they're getting a study done by some of our great outpatient and hospitalists noted that children with neurological disorders are at 5 to 7 greater risks of hospitalization from respiratory infections compared to the general population. And when they get admitted to the hospital, they're in the hospital for longer lengths of stay. They go to the ICU more frequently, and they have longer lengths of stay when they're in the ICU. And therefore, we know the ICU length of stay is a big driver of costs. So this is a study that was looking at community-acquired pneumonia, but I think when we have children with medical complexity, we often think about what kind of pneumonia they have. Do they have community-acquired pneumonia, sort of the normal lobar? But oftentimes, children with medical complexity are labeled as having aspiration pneumonia. And we know that children with complex chronic conditions are more likely to be diagnosed with aspiration pneumonia, and there's been clear associations between the level of complexity and a diagnosis with aspiration pneumonia. This is work that has been done by hospitalists and emergency room physicians in Boston. And then when we look at the comparisons between aspiration and non-aspiration pneumonia in hospitalized children with medical complexity, those who have aspiration pneumonia are more likely to have longer lengths of stay, hospital costs, and ICU transfers, and all-cause readmissions. However, it's really, again, as I was alluding to earlier, this term aspiration pneumonia really is a marker of sort of illness severity, and is probably used as a sort of a name for pneumonia in children with medical complexity, compared to when we think about an adult where they're really looking for an acute aspiration event. So when these kids get admitted who have aspiration pneumonia and children with neurologically impaired, they get a lot of antibiotics. And I think we know this as hospitalists, as general pediatricians, as subspecialties. And this graph is really just to show the difference, sort of the ranges or the variation in antibiotic use. And you can look at the key, but it's really looking at the colors and just seeing that the differences as you sort of go across from left to right in terms of increasing spectrums and differences of antibiotics. So these kids are getting a lot of variation, a lot of different kinds of antibiotics, and unfortunately we don't have a lot of evidence that really guides what are the optimal antibiotics for this population. So one of the things that's been challenging is that a lot of the data that I just presented, just to set up the talk, is really focused on retrospective data that is largely using administrative data sets that have a lot of challenges with them. And so one important group that I want to focus on right now is talking about children with medical complexity with frequent acute respiratory infections is children with tracheostomy. And for those of you who are not clinicians in the room, I just want to review a tracheostomy tube is a tube that goes into a child's neck for a variety of reasons, usually anatomic abnormalities, progression of a chronic illness like neuromuscular disease, or an acute event like a trauma. And it helps to the air to bypass the upper airway to get directly into the lungs. In terms of epidemiology, over 4,000 children undergo tracheotomy placement each year in the United States. And it's a substantial morbidity and mortality. So the in-hospital mortality after they undergo the tracheostomy placement is 7 to 14%. And one of the most common reasons they get readmitted, and one of the most acute post-tracheotomy complications, is what I'm going to call bacterial tracheostomy-associated infections, or labeled B-train throughout the rest of the talk. This includes bacterial pneumonia and bacterial tracheitis. And so bacterial infections are one of the most common reasons that they have a post-operative complication, and also why do they get readmitted to the hospital. But the question I always get when I talk about this is, how did a pediatric hospitalist end up studying tracheostomy outcomes? When we think about tracheostomy, we think about intensivists, neonatologists, we think about pulmonary, we think about our ENT colleagues. But how did I, as a hospitalist, get really interested in this topic? Well, it really came from my clinical care. So it wasn't, Joe didn't mention this, but before I came to Stanford in 2023, I had the pleasure of working at Children's Hospital Los Angeles for 13 years. And in 2010, after my residency at UCSF, I moved down to Los Angeles and started working as a clinical hospitalist 100% of the time. And unlike at UCSF, where we had 2 or 3 patients with tracheostomy, I can name them still 20 years later, I came to LA and there were children like, I don't know, they were putting trachs in a lot of people. And so we were having, and as a hospitalist, I was asked to care for these patients. So we were having over 200 children who were admitted annually with suspected infections. And 90% of them, including the ones who were on a ventilator chronically, were on the floor. So we had a unit of 10 to 15 chronically ventilated patients on the floor, plus all the other patients with tracheostomy. And the majority of them were cared for by general pediatricians or hospitalists, plus minus pulmonology, depending on if they're on a ventilator, and much less often in the intensive care units, so in the PICU or the NICU. And because I didn't have a lot of experience when I was in residency with our 2 patients, who I can still name, I came to LA and I was a new person. I was like, I'm going to learn the evidence. I need to get up, understand a little bit more about this. But what I was finding was that the diagnostic and the treatment plans were changing as teams changed, and I think we've all experienced this. So I would come on service on a Wednesday, pulmonology switched on Saturday, and so we'd have a plan. And then on Saturday, the new pulmonologist would come on and say, actually, we're going to change it. So we went from going home on Sunday to having 2 weeks of IV antibiotics. For me, that was really challenging as a burgeoning hospitalist trying to develop my clinical skills, but it was really challenging for the families because they'd be expecting something, and one hospitalization, they'd go home in 2 days on Cipro through the G-tube, and the next hospitalization for the exact same thing, and they'd be here for 2 weeks of IV antibiotics. And so that really got me thinking a little bit more about what we're doing with these patients and how we can best care for them. So just a little bit about these illnesses, you might have seen the Hello Kitty in the lower right-hand corner, but this Hello Kitty is the mascot for my lab. A father of one of my patients used one of her old trachs that was clean and put it in her Hello Kitty doll so that she could have a doll that looked like her. And it really, it exemplifies sort of what I'm going to talk about a little bit later, but how much our parents are dedicated to caring for their children. So these B trains, or bacterial tracheostomy respiratory infections, account for about 4,500 hospitalizations and greater than $300 million in charges each year. And to put that in perspective, that's about the same number of children who are admitted for a CF exacerbation each year, and about the same amount of costs. So you think about what we've done in CF in the last 20 to 30 years. For most patients, largely our majority patients who are white, we've made it an illness that's going to be lifelong, but not necessarily suffering the consequences that they used to have earlier death. And all the money and all the time we put into CF is great. So now, but we have a population that has similar outcomes, but has not had very much attention. And just like CF, Pseudomonas aeruginosa growth is really associated with the majority of these hospitalizations. So what's known about these infections, about these bacterial tracheostomy-associated infections? Well, we don't have very much evidence, is what I've said. And but we have very limited risk factors and information on timing, risk factors, epidemiology. And so my overall hypothesis for my early career was this leads to care variation, increased healthcare resource utilization, and inconsistent care plans with each admission. So through the support of the CTSI at USC and CHLA, as well as Academic Pediatric Association, I underwent a series of retrospective single-center and multi-center studies to really evaluate what we were doing for these patients after they had their trachs placed and some of the outcomes that they were having. So this graph represents on the middle column is our CHLA cohort that was about 240 patients. And the larger cohort is a multi-center retrospective study using administrative data from 50 hospitals. These are all children who had a new tracheostomy placed. And we're looking at risk factors for the first hospitalization for a pneumonia or bacterial tracheitis. It's always important when you're looking at single center studies versus retrospective studies to compare them and make sure the populations are similar so that we're not extrapolating data from a single center study to a multi-center study. But overall, the groups were fairly similar with the differences that the CHLA cohort was much more likely to be Hispanic and be on public insurance. And because we're a referral hospital, we didn't have inborn like Lucille Packard, much more likely to have premature infants brought to us. And because of our unique home mechanical ventilation program at CHLA, we had much more patients who were on a ventilator, who were discharged on a ventilator. And what did we find? We were looking at risk factors for the first rehospitalization for a pneumonia or tracheitis. We found that there were certain demographic and other comorbidity factors that were associated. First, children who are Hispanic or Latino ethnicity were much more likely to be readmitted for an infection. Those on public insurance were more likely, and while the effect size and 95% confidence interval on our single center cohort crossed 1, we can see the effect sizes are similar. But interestingly, those who are on a mechanical ventilator and discharged on that were less likely to be readmitted to the hospital. And put that in the back of your mind because we talk later on about disparities. And those who were discharged home were much more likely to be readmitted for an infection. So what we see here so far is we'll start to introduce a little bit about health disparities. And we saw that there's multiple factors that are associated with readmission to the hospital. There are racial and ethnic disparities, so Hispanic ethnicity and Black race in the multi-center study that I did not show, public insurance, and discharge home. And as we all know, when a person's race or ethnicity is not associated, there's in terms of any biologic or other reasons. So there's other factors that are likely due to discrimination, bias, access to care that are going to cause these differential associations. But really it boils down to things including systemic and personal racism and bias, both historical and current. So we have public charge rules that set up places where certain people couldn't live, and therefore the property prices were lower, and so their taxes were lower, and so schools are not equitable. That leads to disparities in education, and that leads then disparities in insurance and disparities in wealth and opportunity. And we can look a little bit about language barriers, which affects medical visits as well as home nursing. So just to summarize so far, after getting a new tracheostomy placed, hospitalization for respiratory infections is common, and certain factors are associated with differential readmission risks. And this really suggests underlying health disparities in this population. So once they get admitted to the hospital for their bacterial tracheostomy associated infection, which is the most common reason they get admitted to the hospital, what do we do for them? They get admitted to the hospital. Well, we do a lot of tests, a lot of blood work, a lot of trach cultures, x-rays. We give a fair amount of antibiotics. And depending on the hospital that you're in, you're going to be doing some consultations to maybe your pulmonology colleagues, infectious diseases, critical care. But as I alluded to earlier in the beginning of the talk, we really don't have any current knowledge about what was happening to these patients on a larger or national level once they got admitted to the hospital. So through some work that I did, we published 2 papers looking at sort of what were the care variations and outcomes for these patients, and patients who had an existing tracheostomy who were readmitted to the hospital for an infection. And I'll just present some of the work for one of them, which was a multi-center cohort study, retrospective of 4,000 children who were admitted and treated for a respiratory infection. And what I wanted to know was, what are hospitals doing like right now? We don't have any clinical practice guidelines. We don't have any standards that we can apply to the population. So what are people doing with them? Well, we found that there were really large variations in the diagnostic testing as one marker of sort of the need for some of these clinical practice guidelines. So while most children who had a bacterial respiratory tract infection and were treated for that infection got things like x-rays, complete blood counts, and respiratory cultures, and there was little variation in that, we saw things like viral testing with wide variations from anywhere from 4% at the hospital of patients at one hospital to 66% at another hospital. So patients were getting a lot of testing, but it was really one of the things that was unclear was how does this testing actually affect the practice that they're doing and the clinical care that they're providing? So what we found was that the hospitals that had a lot of utilization, so we're using a lot of tests, had the same outcomes as hospitals that had lower utilization, meaning that they were not doing as many CBCs, viral tests, and x-rays. And when we look at that, when we see variations with no difference in outcomes, that really tells us that there's some degree of overuse or over-testing that's really not positively influencing the clinical outcomes. And why is that? And it's because we don't have any clinical practice guidelines. So if you think about the clinical practice guidelines that we, these pediatric hospitalists and generalists use normally, we have guidelines for pneumonia, bronchiolitis, asthma. And these are guidelines that have been, are reaffirmed, and the evidence is updated on anywhere. Sometimes it's a few years, but sometimes it's tens of years. But the first thing that they do is they exclude any child who has complex chronic conditions or other medical problems. So our bronchiolitis guidelines exclude any child who's not otherwise healthy. And by doing that, while we sometimes need to do that in order to make sure that the guidelines we're providing are consistent for the majority of the population, by excluding those patients, we put them at a disadvantage for being able to provide the care, evidence-based care, because we're not generating evidence about them. So after that, I really sat down and thought a lot about where were the gaps. So I'll just say at the end of my KL2, which was in 2017, we had a lot of this data that I just presented. And for those of you who are sort of burgeoning researchers, you sort of sit down and say, where are we at and where do we need to go? And I was trying to think about where are the gaps in literature. And one of the key gaps that I had was we had evidence that there was variation in testing and that wasn't really changing outcomes. So the question was, how are people utilizing all those tests that they're doing to influence their care? So how do clinicians use things like respiratory viral testing, culture results, our inflammatory markers, to choose to continue and treat with antibiotics when patients are getting evaluated for suspected bacterial tracheostomy-associated infection? The second sort of key knowledge gap was because these patients get so much antibiotics, and there's not any clinical practice guidelines, there was no guidance about what antibiotics should be used in the population and how long they should be continued for. So the second knowledge gap that I identified was what factors influence clinicians once they've diagnosed somebody with a bacterial pneumonia or tracheitis to continue to use broad spectrum antibiotics during their treatment. So if you've already decided they have an infection and you're giving them antibiotics, why do some patients get meropenem for 14 days and other ones, maybe they get ceftriaxone for 7 days, or they go home on oral or enteral antibiotics? And the third one that came up, and this came up repeatedly in discussions that I was having as I was presenting this data, one-on-one meetings with pulmonologists, critical care colleagues, physicians across the country, was these children always grow pseudomonas. They grow pseudomonas more than half the time. But what does that mean? And I would talk to some pulmonologists and they'd say, you know what, these kids always grow pseudomonas, so I'm just going to treat them with sort of narrow spectrum antibiotics, and if they don't improve, I'll broaden them. Other people said, how could you ignore pseudomonas? And they were sort of in the CF model where pseudomonas grows and needs to be treated no matter what. And so the question was, does the detection of Pseudomonas actually always warrant these broad Pseudomonas targeted antibiotics? And can we figure out who might benefit from that? So this brings me to sort of talking a little bit about my current work, which the second half of the talk will be about that. But before I digress, I talk a little bit about my work, I wanted to just talk about some of the successes that I've had, because I think it's really important to note those, but also to say thank you to the people who have helped me out. So as Joe had alluded to earlier, I was fortunate to get a KL2, which is a career development award, which protected 75% of my time. I was able to get a Young Investigator Award from the APA. I got a sort of a local voucher to like fund some of this other work. And then, one of the most impactful things in my life was getting loan repayment. So for those of you who don't know me, I was the first person to go to college in my family. Obviously the first person to go to medical school. And loans were a big thing. And so getting loan repayment allowed me to do the research that I'm doing without worrying about hundreds and hundreds of thousands of dollars of debt. It was a sort of a joke because while I had a lot of successes, there are a lot of failures. And I think it's really important to note those. I think people think when people get Harvard Grand Rounds, oh, like they get everything, they get all the grants, all the papers published. No, I had a lot of failures in that same time frame. And I tried to transition to an external career development award. My grant was not discussed 3 times. So I didn't even get to the top half of discussion. For those of you who are underrepresented in medicine, the Robert Wood Johnson has this AMOS program, Harold Amos program, which is a career development award. Likewise, I tried 4 times to get it. I got an interview the 3rd time and wasn't chosen. And besides those, I have multiple other small grants that I didn't get, and that continues to this day. And the reason why I bring this up for those of you in the audience who are a little bit more junior and who are trying to go along this path is just recognize that even people who are doing well, including myself and many others at this institution, have a lot of things that are not successful, and that's okay. And just thinking about how we can support those people is really important, which is why I do the work with the mentoring and other work that I'm doing to this end. But something will hit. So if you keep submitting, something will hit, which is the other thing. So I was so fortunate. So I submitted my first R01 in September of 2019. And as I was waiting for it to get reviewed, because they get reviewed like 6 months later, I also had been submitting a foundation grant. And the Gerber Foundation, yes, the Gerber baby food, they have a foundation that's separate that funds predominantly work looking at younger children. And I found out right after I submitted that initial R01 that they were going to fund me for a 3-year project, which allowed me to do some of the foundational work that helped support the successful resubmission of my R01 years later. So the Gerber Foundation funded me in January 2020. And when you're studying respiratory infections in children in 2020, this is another thing, sometimes things happen. And I was really worried because I think as we all saw in the pediatric hospitals, our admissions plummeted. And they were doing a good job not exposing kids to respiratory infections, and particularly our parents of children with medical complexity. And I was really, really worried because the whole point of this grant was to get the data to be able to show that we could recruit the patient population that we needed at the numbers we needed to show feasibility. So we worked really hard, and we got because we were supposed to kick off in March of 2020, and clearly things did not go that way. But we were able to, despite that, at least generate that even in the COVID times, acute COVID pandemic, we were able to recruit enough patients for feasibility for our study. So I just want to point out, this was a consortium of 6 hospitals across the country. And what we were doing was we were recruiting and enrolling patients who had an existing tracheostomy, who were 21 years and younger, and who were being evaluated for a suspected infection, respiratory infection. And the way we defined that was they had a respiratory culture sent from their tracheostomy tube, and they got antibiotics for a suspected infection. And really what we were trying to do is see, we know that there were variations in the testing that was being done, but because we didn't have test results or other key data from that retrospective study, we wanted to see prospectively, if we collected additional data, how would that impact what were the things that impacted the decision to treat with antibiotics for a complete course. So our outcome of interest was treatment for an infection, which I'll show in the next slide. We also excluded patients who received antibiotics within 7 days prior to hospitalization, just because pretreatment can affect your culture results, and that would make it difficult to attribute the culture results to the outcomes. So I had the pleasure of working with, as I said, 6 hospitals across the country, and one of them included one of a now K23 awardee at Johns Hopkins, All Children's in Florida, and I'm so excited to be one of the co-mentors on his K23, and he really led sort of some of this foundational work. So he was really interested in the Pseudomonas question, like how does Pseudomonas affect our treatment decisions? Because Pseudomonas has grown in the majority of these patients' populations. So his primary predictor was growth of Pseudomonas on your respiratory culture, and the primary outcome was what we call B-train treatment, which is, I guess you guys can't see it here. And just like there are no clinical practice guidelines, there's also no definition of what a pneumonia or bacterial tracheitis is in this population, right? So we made the decision to make it broad for this project. So we said that there was a discharge diagnosis from the attending physician in the discharge summary that they had a pneumonia, a bacterial pneumonia or bacterial tracheitis, and they were being treated for that. And they received what the team considered a complete course of antibiotics, which was we broadly defined like whatever the team said was a complete course, because there's no clinical practice guidelines, so we don't know, is 3 days okay, is 5 days okay? And we'll get to that a little bit later. But we were trying to figure out, does this growth of Pseudomonas on respiratory culture actually impact the decision to treat somebody with a complete course of antibiotics? And we had a lot of comorbidities that we adjusted for. There are demographic and historical comorbidities, acute clinical comorbidities, and then diagnostic test results. So not just getting the test, but actually what the results were. So this is from the Gerber project, right? So it was a 2-year project during COVID. So we were still, despite the precautions that people were taking, we were still seeing admissions, and we had 549 encounters at the 6 hospitals for suspected pneumonia. Just about 16% of them, or 98, had already gone antibiotics before they were hospitalized, so we excluded them, which left us with 451 encounters, which represented 293 unique patients, because patients got readmitted more than once for an infection. And we saw that out of those who were admitted, it was about half and half that got treated for an infection and did not receive treatment. And so the cohort, just in terms of who they are, overall they were school age, so the median age was 4. We're equally male and female. And what I really was really happy and really glad to see was the racial and ethnic, that we had a large proportion of patients who are minoritized in our population. And it was really important for me to have a great, to not just, because a lot of studies, as you saw earlier, the cohorts were not that diverse. So that it's diverse. So we had over 50% of the patients who were included were from a minoritized background, so Hispanic, Latino, or non-Hispanic Black. And then the other thing that was, eye-opening to me, not surprising, but continued to be eye-opening, is that most of these kids lived at home, right? 76% of them lived at home. And if you look, although 76% of them lived at home, only 61% of them had home nursing. So there was a gap of about 15% who did not have home nursing. And it's not presented on this slide, although 81% of them had some type of respiratory support, the most common respiratory support at home was a ventilator. So we had families without home nursing, taking care of children on a ventilator 24 hours a day. And just remember that, because we're going to talk a little bit about home nursing at the end of this talk, and the disparities in that, because I think it's one of the greatest burdens that our families are facing today. But overall, there were no differences. Although this is the population as a whole, there were no differences, major differences in the cohorts who were treated and who were not treated. So when we look at the multivariable model, we actually found that growing Pseudomonas on a respiratory culture was actually, at least in our cohort, was not associated with any differential risks of being treated for a pneumonia versus being evaluated for a pneumonia or tracheitis. We did find that there were certain acute clinical factors, and I think it's not surprising. Patients who were hypoxemic, patients who were having respiratory distress, who were on a ventilator and needed more ventilators support or needed to be put on a ventilator, were more likely to be treated for an infection. I think that's pretty standard. And not surprisingly, again, children who had abnormal chest x-rays were much more likely to be treated for an infection. I think then, and then we looked a little bit at laboratory testing. And this is where it got a little bit interesting. So I think, again, not surprisingly, the more white blood cells you had on your tracheostomy gram stain, the more likely you were to be treated for an infection. And there was sort of a stepwise relationship between that. But interestingly, and this was, again, during the acute phase of the pandemic, patients who had a positive viral test, these are all rapid PCR-based testing, were actually half as likely to be continue to receive antibiotics for treatment. So a positive viral test was associated with the discontinuation of antibiotics, which, given the conversations I had had around the country with our pulmonology colleagues, our hospital medicine colleagues, and other people, was surprising. And just because people were not talking about viral testing and stopping antibiotics as much as sort of the data was showing. So, we were left with this data, which was compelling. And as a hospitalist, one of the things I wanted to do was think about how we can develop clinical practice guidelines. So how can we use some of these test results? So, if you have a gram stain that shows no white blood cells and you have a positive viral test, should we be recommending stopping antibiotics? But we recognized that this was in the early stages of the pandemic, and we needed to do more work. And thankfully, the Agency for Healthcare Research and Quality recognized that this work was important. Pediatric patients were a priority population, and also recognized that we demonstrated feasibility despite the much lower admissions for respiratory infections, and so supported my successful application, which was funded in August of 2021. So this is now years later after I submitted it the first time in summer of 2019. So just again, patience is important for if you're going to be a physician scientist. And what we were doing is we were expanding so we had the same hospitals, but we really markedly expanded our data collection to look at clinical outcomes, to drill down more granularly on sort of the amount of support, the days of support, which was not able to be done using the limited foundation funding that we had. So like I said, in August of 2021, I was fortunate to receive a 5-year R01 from the AHRQ. And this is I'm going to do one more sort of detour, because we're talking about racial ethnic disparities in our patient population, which we're going to continue to talk about. But I also want to talk about racial and ethnic disparities in NIH funding. So if you look at these graphs, these are the number of unique NIH R01 equivalent Black awardees on the left, and then Hispanic awardees on the right. So you'll see, good news is these are going up. So these historically minoritized groups are getting much more likely to get R01 level funding. It's doubled over the course of a decade. But I want you to focus on the absolute numbers. For Black awardees, it was just under 200 in the year that I got mine, which was 2021. And it was just under 450 in 2021 for Hispanic Latino colleagues. And I just want to put that in perspective. There were over 5,000 new R01s funded in the same year that I got mine. And so, we're saying we're making progress, but if you look at the populations, it's just there's still wide disparity. So thankfully, the NIH has put a lot of effort into trying to improve these disparities, and a lot of work into diversity supplements and other support. But just remember that for those who are on the Zoom or in the room who are particularly from a minoritized background, it's an even more challenging road because of these disparities that are persisting, but hopefully improving. So what did we do for the R01 that was sort of different from the Gerber grant? So really we were looking, we wanted to confirm the rapid viral testing and decreased antibiotic use in a larger cohort, and a cohort that was not in the acute pandemic. And so looking at what fact did people use rapid viral testing to influence their continuation of antibiotics in patients who are admitted for suspected bacterial tracheostomy associated infection. For those who were treated, what are the clinical and laboratory factors that are associated with continued antibiotic overuse in that population? And then the one that's the most interesting to me is really looking at the Pseudomonas question. So we're doing prospective data collection where we're going to match patients who have using propensity score matching to adjust for confounding by indication, looking at patients who grew Pseudomonas who were treated with an anti-pseudomonal versus those who were not, and looking to see, do they have similar outcomes? Do they have different, are they non-inferiority, are non-pseudomonal antibiotics equivalent to those that are pseudomonal covering? Because if we can show that the biggest driver of hospitalization in this population, one of the biggest drivers is IV antibiotic use for Pseudomonas. So we really want to try to break the sort of and interrogate that question a little bit more deeply. So what we did for the R01 is we really expanded, and we have this same multi-center prospective cohort study with the same inclusion criteria, although we're including patients who were pre-treated just because we're going to look at how pre-treatment affects your testing. And I'm just going to present a little bit about the study cohort right now. We're in the midst of data cleaning and in the midst of some early analyses. So stay tuned for that. Some of it will be presented at PAS 2024 in a month or so. But the data here are for the sort of the first 2 years of the R01. And just for everyone, our goal had been to recruit 1,500 hospitalizations in 4 years because we were really powering for the low end, because we didn't know what was going to happen after COVID. But again, I think as we all saw, respiratory infections came back with a bang. And unfortunately for our patients, they were getting admitted much more commonly. So in our first 2 years, we had 1,461 hospitalizations representing 700 patients. So we met our inclusion, we nearly met our target enrollment just in the first 2 years, which was just showing you how much these infections were increasing once we lifted our acute COVID pandemic precautions. And we just wanted to say it was a similar median age of the cohort that we have now, which is 4. And we continue to recruit a racially and ethnically diverse population, again, with more than half of them in a minoritized background of Latino, Hispanic, or Black or African American. As part of our expansion, we're really drilling deep to identify languages for the families, and 19% of them have a non-language English language preference. And then we continue to have a cohort that's at risk for health disparities. So 82% of them are on public insurance. And we're actually seeing now that more of the children are living at home. And I think that that's probably due to the challenges that happened in the acute COVID pandemic, where families were not able to see their children. So if you lived in a subacute facility, we had parents that were not able to see their children for a year or 2 years. And so some of them were taking their children home, again, largely some of them without home nursing because of that. And then this sort of breaks out the respiratory support. So we can see that 65% of them were on a mechanical ventilator, and most of those children, again, were at home. And so I just want to say we have in terms of representing the population, we have a largely minoritized population, and many of them do not speak English as a primary language, who are on Medicaid insurance, who are taking care of children with tracheostomy and ventilators at home, primarily. And so we're thinking about health disparities and challenges in caring for these patients. We have to keep that in mind. And we found that just so we, in terms of the cohort so far, 88% of them underwent rapid viral testing, and about 25% of those of the total admissions were associated with a positive viral PCR, so 1 in 4. And similarly to the Gerber cohort, so thankfully, we're seeing similar sort of rates of treatment and rates of viral testing. And we're currently doing the analysis to look at sort of the association between viral testing and outcomes. And not just antibiotic treatment, but also looking at, for those of them who were not treated and antibiotics were discontinued, did they have increased readmission rates? They have increased transfers to the intensive care unit. And I will say that that's, I'm not showing the data now, but we're at least preliminarily, we're seeing no really increased rates of hospital readmission in those populations. So maybe some evidence that not giving stopping antibiotics when you have a positive viral test may be safe. And for the 45% that were not treated, most of them were diagnosed with a viral illness, but we're seeing still a large burden of urinary tract infections in that population, which some of my co-investigators, Dr. Katie Forrester at Pittsburgh, is really interested in UTIs and medically complex children, and so we're going to be focusing on that as well. So I want to end just with talking a little bit about why I came to Stanford. So really, and there are there are many reasons why I came, let's be clear, but really, and many of them are in this room right now. But I think I pulled some memes off of, like, I put in like career change or like pivoting, and like these were like the things that popped up. So that's why. But I want to talk about some impactful experiences the last few years I was at CHLA that prompted me to think about larger questions in children with medical complexity. So the first one is a patient. His name is Chris as well. I've known Chris since he was an infant. He had a myopathy that was progressive. He had received a tracheostomy in my first few years at CHLA. He was placed on a ventilator, and I followed. And all children with tracheostomy and ventilators are on the hospital medicine service in Los Angeles with pulmonary co-follow. So I knew his mom, and I saw her all the time. And his initial hospitalization was discharge was delayed because we could not find a Spanish-speaking nurse, and his mom refused to go home with having someone in her house 16 hours a day who did not speak Spanish, which I think is reasonable. That would be really odd to have someone in your house you can communicate with. And through the network of moms, someone gave up, was like, oh, my child's getting better, I'm giving up my nurse now. And like literally in the hospital, the moms were talking about the nursing. And like, here, I'm gonna give you my nurse, she's great. So they're helping each other out. But like the fact that they're doing that, but we still couldn't provide it was really frustrating. And as we all, based upon the talk that I just gave, Chris was admitted frequently for respiratory infections and other illnesses. But he was readmitted in 2020 for a respiratory infection. And I think we all know what was happening, not just COVID, we had the George Floyd, Breonna Taylor, all of this stuff was happening. And I frankly was in a very difficult, challenging place. And I walked into his room, and his mom did not look like herself. Like, I've known this woman for a decade, right? And I said to her, "What? You don't look like yourself. What's going on?" She's like, "I'm really tired." And I said, "Okay, when's the last time you slept more than 2 or 3 hours in a night?" And she said, "It's been years." And for me, I think I knew this intuitively, but to have a mom directly say that to me and call it out just reminded me of what our families are going through, right? This is sort of a one mock-up that Chris Feutner, who's the division chief of general pediatrics and hospital medicine at CHOP, he's done a lot of work with palliative care as well. It's sort of the illness trajectory that might fit for Chris, where he gets diagnosed with the disease, he gets an intervention, he has acute exacerbation, so these respiratory infections cause him to decline in his condition. We can tune him up a little bit, but he never gets back to where he was at baseline. And then he has another one, and then it's this constant until death ensues years later. And while this is the child's trajectory, this is also the family's trajectory. As a child gets sicker, the families are not getting back to their baselines. And so they are taking these progressive hits in terms of their quality of life as well. And then a second really impactful experience for me was at PS in 2023, so last year. And in full disclosure, yeah, I had already been thinking about a transition at that point, but this was something else that helped me really change my lens about what I was going to do when I moved. And so we had our hospital medicine platforms are always really interesting, and we had 6 platform sessions that were all about racial and ethnic disparities. And I wanted to highlight Dr. Castellanos, who's one of our colleagues in pediatric hospital medicine at Stanford, who joined around my time, who was presenting one of these abstracts. And it was really great to see so much about focus on disparities in a pediatric hospital medicine plenary session. It was hard though, also, because we were sitting there, we were talking about Black and brown children and Hispanic children are more likely to be put in restraints for an acute when they were here for a mental health crisis. They're more likely to be tested for their mothers are more likely to be tested for drugs of abuse when they had when they're just an otherwise healthy baby newborn. And they were having disproportionate effects on their social determinants of health. And so I was sitting in the audience, and at the end of it, I stood up and I said, it's really great to see all of these platform presentations and this focus on disparities, but when are we going to move towards equity? When are we going to move to like not just defining the disparities, but moving them and decreasing them? And that really was like a frame shift, another frame shift for me, to think about how I and my team and my research could really positively impact our families' lives, not just identifying those disparities, but changing them. So just a little bit, I'll end a little bit about quality of life in children with medical complexity. We all know that the quality of life for caregivers of children with medical complexity is lower than that of the general population, despite the pleasure and joy that they get for taking care of their child. And one of the drivers of poor quality of life is unplanned inpatient hospitalizations. And as a hospitalist, that's where I can affect change. And we know that lack of home health nursing, or HHN, availability is associated with higher readmission rates and delayed discharges. So we're increasing lengths of stay for patients who are already experiencing frequent hospitalizations and are at risk for having disparities. And when these children are at home, that care largely falls upon the caregivers of the children with medical complexities. So their parents, their grandparents, their aunts and uncles, their brothers and sisters, and other siblings are taking care of them. And interestingly, a recent study was sort of asking the families to identify how much time they're spending doing this, and these caregivers are spending 52 hours a week on health-related care at home. So this is not necessarily being mom or dad. This is like a direct health-related care. And I think I've heard people say, well, you know, the families enjoy it, and they do. They get a lot of pleasure. I mean, they obviously, they love their children, but it's not parenting when you're having to do all of this medicalized care for your child at home. And the other thing is that this home health nursing is not equitably available. So as Chris's mom pointed out, and the research shows, caregivers from minoritized backgrounds or who live in poverty are disproportionately required to provide more home-based care. And so an anecdote was one of our patients could not get home health nursing because no home nurse felt safe going to their neighborhood. And so there's a lot to unpack there potentially, but we know that when we actually support families in caring for their children, the children have the same outcome. So Dr. Carolyn Forster, who's a general pediatrician at Lurie Children's and a colleague and collaborator of mine, looked at this unique model in Colorado where they train families to be certified nursing assistants. They give them the actual certification. They pay them that way. And shocker, the children, they have higher retention rates, so the nurses don't churn. And they also have basically the same number of hospitalizations per day. So really paying families to care for their children like a nurse and training them for like a nurse actually results in the same outcomes. And if that child no longer needs nursing, that parent is trained to help another caregiver, another child. So Colorado has this model. This model is happening also in Washington State, where it's going through the Senate right now. So in Washington State currently, parents can't get paid for caring for their child with a disability, or anyone can get paid except for their parents, sorry, because parents are expected to do that, 52 hours of extra work. So in in Washington, they're trying to make changes. And now in California, we have some programs like in-home support services, but it's not the same amount of support that some of these families are getting. So I'll just close by saying, I decided after some amazing conversations with many people in this room and all of the great researchers to move from LA to back up to the Bay Area and to Stanford, where I'm so excited to be able to work with such an amazing group of colleagues. And as I think, sort of all joking aside, it's got to be Stanford. Where else would you go, right? And so I'm really excited to be able to really move some of that work forward, thinking about our families and caregivers. So I'll end by just saying, we know that respiratory infections, internal medical complexity, high morbidity and mortality, there's not a lot of rigorous prospective research, and we really need more prospective trials, including randomized clinical trials in this population to affect our guidelines. And with that, I'll acknowledge many people who have helped me, both when I was in LA, my lab staff, my current mentors and collaborators here, as well as my collaborators across the country and my funders. And with that, I'm happy to take any questions.
Thank you, Dr. Russell, for that enlightening talk. Here we thought we were going to talk about medical complexity, which you did a great job in, but also enlightening us in so many other areas about health inequities and the load on our families and our parents who take care of these kids. So thank you so much. Lisa?
Oh, Chris, thank you so much. We're so glad you're here. What a fabulous talk. I agree with you. Time to move from description to some action and moving towards equity. If you had to prioritize an agenda for community engagement, for policy engagement for us here at Stanford, our local community, we've got some very longitudinal relationships with so many community partners, and or a policy agenda for Sacramento, what would you highlight?
Yeah, I think, so I want to recognize that I'm coming at this with where I think the levers are, and I think that it's home nursing. But I think the first step is really, and that's the work that we're going to do, is really thinking, working with the community partnerships and doing community engaged work to figure out what do the families think. I mean, I've heard home health nursing from them, but I think respite care is another big thing. How do we give families a break when they're taking care for their children? And I do think this this training and paid caregiver is an interesting model that, but I think it starts with the families and figuring out what they want. And I don't want to speak for them, but that's where I would start with thinking, really bringing these families together and developing their own agenda.
Dr. Mendoza.
Great, great talk on both sides of the science and how we apply science to people. And I think your question about how do we make pediatrics fit our community is really key, and not just now, but for the future. Half of all the kids in the United States are kids of color, minority kids. That will grow in your lifetime to 2/3. Mm-hmm. And I think we sit in the most diverse county of all California. So we can lead the ideas about how do we treat, as pediatricians, that population. That is going to look different. It's going to have all kinds of differences that we need to adapt. And particularly when we have really sick kids. Yeah. And I think that agenda needs to be certainly nationalized, but there needs to be really good data to support that movement. And I think your kind of work will really help us understand that. So I really congratulate you.
Thank you. I mean, I also think we have to get pay parity for pediatricians and internal medicine, which I know many people in this room have been working on. But yeah.
Chris, it was a great set of thoughts, and the presentation was wonderful. And I wanted to extend Lisa's question because I can't help wonder about the institutionalized racism at the community level and whether the time to start providing resources to families is before they ever get pregnant. Yeah. And how do we put that together in the context of the care afterward for children with special healthcare needs?
Yeah. No, I mean, I agree 100%. I think we were looking at some data last Friday, and I was just struck again by the racial ethnic disparities in prematurity again. And it was like, it's a reminder, and I think it can't start once the child's already, got a trach on a ventilator. It needs to start from the beginning. And that's where we talk about this redlining and how do we get, equal resources to them at the earliest stages and Head Start and things like that.
And I guess to extend that, can you overlay the community's investment in resources for those populations on the outcomes and on the risk factors to be able to demonstrate that from these data or from future data?
Great. Thanks.
I think we're going to take our last question from over there.
Thank you for your talk. I'm thankful for the families that are up here now, getting you to take care of them. That was very inspiring. Sort of piggybacking on the topic of what to do before admission. Are you looking at all at differences in hospitalization, standards of hospitalization? This kid needs to be hospitalized because so many of these kids are getting so much of their care not at the hospital.
Yeah. I think as a pediatric hospitalist, I focus on sort of the acute hospitalizations, but obviously a lot of the work
dumped on your lap.
Well, no, I mean, I think the families are actually, how do we support sort of families at home to be able to manage some of these conditions when they can? Because we're asking mostly moms to become ICU nurses at home, right? They can do this. I mean, that's what they're doing day to day, is an ICU level care of their child at home. And how do we support them? So there's been some really innovative work out of Boston looking at hospital at home and how do we, like, going to the house as a physician. I know Justin Baker from the new Division of Quality of Life and Palliative Care is thinking about how we do hospital at home for these children. And also, one of the challenges that we do have is that there are such differential admission requirements and comfort level with families. So potentially the more resources you have, the more likely you feel comfortable to stay at home. And
the more what?
So the more resources you have at home. So like if you have home nursing or you have a family that's supportive and able to sort of step in when you're not feeling, like primary caregivers aren't feeling well, you may feel more comfortable staying at home and for a few days. But there are other families who have been, like Chris's mom, who 24 hours a day for years. Any little setback, he's gonna have to be hospitalized because she's not gonna be able to provide that. So I think thinking about how we support that hospital at home is another important thing.
All right, thank you so much. And I think that will conclude today's Grand Rounds. Chris, again, thank you and wonderful present.
Thank you. Thank you, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.